Facing Africa airway equipment for the management of NOMA cases. And I'm just going to show you an array of equipment we have. This first clip will involve the fiberoptic intubation equipment that we use. We've had extremely generous donations from Karl Storz Endoscopy Germany, who've donated us a Telepack. So we've got an integral camera system along with two reusable intubating fiberoptic scopes. So we have the first one is a 5mm or fat scope, if you like, and the second is a 3.8mm or thin scope. So these are reusable devices which we plug into with an integral light source and camera, and they plug in and we display on the monitor. So the beauty of that is we can teach and train and everyone can see what we're doing. Prior to this we used, again, generously supported from Olympus, fibre optic scopes which we used through an eyepiece. So you have the difficulty of looking down and then passing the scope to someone else, for example, who's learning and looking backwards and forwards. So the facility of that screen is really tremendous. We've also recently acquired some Ambu 2 disposable, would you believe it, fibre optic equipment. So these come with disposable fixed 5mm external diameters. They require they have an integral light source and it requires a monitor to display the images. So although this seems extremely wasteful, the advantage of this is we've had a small but steady number of patients who require fibre optic airway management who additionally are HIV or hepatitis B or C positive. Just briefly in conclusion with in regard to fibre optics, we have, depending on the surgery, we're looking at using oral tubes. So our two choices for those will be either preformed oral ray tubes of a variety of sizes. The other alternative to that is an armoured reinforced orotracheal tube. So that's for the oral route. For the nasal route, our two options are once again armoured tubes or nasal north-facing endotracheal tubes, which are single use. In terms of completing our fibre optic or intubation, there's a miscellaneous selection which is really important to have. So we need to have swabs, we need a lubricant gel for both the fibre optic scopes and also for tube passage. A number of our patients require nasogastric tube placement for between 24 and 48 hours after major perioral or facial reconstructive flap surgery. Throat packs are used routinely. The eyes are protected with lacrilube, and prior to nasendoscopy it's always useful to use a vasoconstrictor. A patient having a nasal fibre optic intubation for a Trismus release. This is not an anticipated difficult airway, either from the point of view of mask ventilation or from intubation. The patient's able to open their mouth widely, and we would be able to access with conventional techniques. So we're under general anaesthesia, paralysed and anaesthetized, and we're going to prepare the nose at this point with a vasoconstrictor, and this is Otravin, probably preparing both nostrils, both of which are patent, are they not, Alice? Yes. Okay, so we'll give that a few seconds to take effect. And the next step will be to perform a nasendoscopy, and follow that up with the fiberscope, which is loaded with a 6mm north-facing nasal tube. Through the nose.
Yeah, you are filmed.
It's quite a nice image. A little bit of rotation. Now, I'm probably going to need a jaw thrust. Agree? Okay, so we're in the back of the nasopharynx now. We've navigated the nasal cavity. And Gru is kindly doing a jaw thrust for me. A little bit of a narrow space here. So try and find a clear spot to go around. Some secretions here. And that's the epiglottis in the distance there. Nice view of the epiglottis, larynx, arytenoid cartilages. So I'm just going to navigate under the epiglottis, directly for the laryngeal inlet, over the arytenoid cartilages, then a bit of leverage into the trachea. Nice view of the tracheal rings.
What is your orientation point?
My orientation point?
Yeah, how do you know where you are?
Oh, okay, so I can see the tracheal rings going all the way down. You might need a little propofol. I know he's had a load. Have you? Thanks. And the muscularis or trachealis. It's a trachealis muscle, isn't it? Anteriorly? Posteriorly?
Yep.
So I'm just moving down to the carina now. It's a nice view of the carina there. Okay, now what I need to do, thanks Gru, that's probably okay now. I need some Alison KY gel on a swab.
So explain your tricks.
Okay, so we're going to lubricate the scope now, between where the scope and the tube is.
It's going to rain in the tube.
Why do you do that?
In order to allow it to traverse or railroad over the fibroscope freely. Now what I'm going to do as well is orientate the bevel of this thing so it points posteriorly. So if you can take a look at the bevel is pointing posteriorly. So I'm going to just slide it off the tube now, try and keep the cuffs a little inflated actually. And can you just deflate that fully for me with a 5mm syringe? SATs are okay, aren't they? Okay, so I'm going to try and just slip that off through the nasal passage. It's very easy to advance the fibroscope, so I'm trying not to do that. So my bevel's pointing posteriorly all the way, and we'll see if that just slips in nice and freely, which it should do. I've still got a view of the carina, and that's us in.
So you have tricks for the...
Okay, so the bevel points posteriorly and that avoids catching on the arytenoid cartilages posteriorly. So that's the tube gone in as far as I want it. I'm going to advance the scope down to the carina. Okay, Gru, can you hold the tube for me?
I'm holding.
Okay, at this point now I'm going to withdraw the fibroscope with a lever neutral so you don't damage any of the fibers. I'm going to measure the distance before we enter the tracheal tube. So there we are, that's the tip of the tracheal tube. So if you look where my fingers are, it's a 5 centimeter distance from the carina to the tip of the tube. That's super, and that's where you'd expect the bend to be on the north-facing north polar tube anyway. So I'm going to just withdraw the scope all the way. That's us. Great. So now we need to inflate the cuff.